Good afternoon, everyone. Hopefully today we're going to learn about your story, but my exam and what becomes of it. Okay, chronic pelvic pain is presented because the bladder lives in the pelvis, and almost everybody with bladder pain has pelvic pain. So the duration, it has to be at least 3 months. The location, pelvic, lower belly or abdomen, lower back, the inner or medial aspects of the thigh, into the groin or inguinal area. The perception is variable among each patient, whether it's sharp, burning, perceived as pressure or discomfort, a dull ache, or throbbing. And is it persistent or continuous, or is it recurrent, episodic, or cyclic in women with the menstrual cycle? Okay, so a little bit about what you're going to hear. A syndrome is a complex of concurrent symptoms and signs that is collectively indicative of a disease, condition, dysfunction, or disorder. It can be nociceptive in the non-nervous tissues. It can be somatic, which is usually aching and throbbing and localized. It can be visceral, which is usually intermittent, poorly localized, and in the viscera or body organs. It can be neuropathic, which usually is associated with a lesion, and we call that somatosensory. It can be centrally generated, like we have chronic regional pelvis pain syndrome, and it can be peripherally or a mononeuropathy. You've probably all heard the name pudendal nerve entrapment. Okay, so what is this chronic pelvic pain in terms of their syndromes? Lower urinary tract, male genital, female genital, gastrointestinal, musculoskeletal, neuropathic, psychological overlay, sexual aspects, and all the comorbidities that we see with bladder pain syndrome, interstitial cystitis. So then, your story is your history, and that's the symptoms. Again, onset and duration. Was it sudden? Was it gradual? Is there an inciting event? A fall down the stairs, a fall off of a horse, bicycle riding and falling onto the seat repetitively, a motor vehicular accident, recurrent urinary tract infections, or your first one, catheterization, pelvic surgery or other surgery, hormonal changes, or a stressful life event. Now that's the inciting or beginning event, and then there's often the trigger, which is where we are now. And that can be, for example, a recurrence of a urinary tract infection, having a car accident and then having a fall. And this is right after the fall, being catheterized after a delivery in the hospital, going through menopause or menopause. So, or you can have any one of those that have just been mentioned. Okay, where is the pain? Again, lower abdomen, which is the suprapubic area over the bladder, the lower back, the medial thigh, at the vaginal opening, which can be the skin or the penis, the testicles, inside the pelvis, way up inside. Not sure, just down there. Very common until you start to get better. Other areas of the body in addition to the pelvis, which is why you may be asked to fill out what's called a pain map, which will show us the location by the dermatomes, or where the nerves supply the skin, in the different areas of the body that can help us locate and you describe your pain a little better. What provokes the pain? Urination, defecation, sex, which painful sex is called dyspareunia. And if you're the male partner of a woman with mesh surgery, it's called hispareunia. Is the pain constant or intermittent cyclic? Is it associated with acidic diet, tomato, alcohol, and the biggest one, caffeine? Stress, whether it be emotional or physical. Did you get sick? Did somebody in your family die? Or did you have a horribly stressful event? Body position. If you have pudendal nerve entrapment, there's no pain when you're lying down. And what exercises like bicycle riding, rigorous exercise trigger your bladder pain? What relieves the pain? Well, in many people, they have pressure or pain associated with bladder filling, but when the bladder is emptying, the pain tends to go away. Defecation may make it better. Doing pelvic floor physical therapy with a home exercise program may make it better. Deep breathing, yoga with stretching. Home exercise program again, using a dilator or wand taught to you by the physical therapist. Acupuncture is another that's very good at relieving the pain. All of these help to reduce stress. And we do know that the pelvic floor is the center of the universe. So if we can breathe through the pelvis, we can relax. And bladder analgesics, azo, we've heard of, perineum, things that make the urine blue. What bothers you the most? Well, some people would say urgency. Some people would say bladder pain. Some people would say pelvic pain. Some people would say there's different kinds of pain. So that's why, as we're going to see, we have different questionnaires to give you to help you and me figure out what bothers you the most. And then what else can you tell me? What did I forget to ask you? Everybody's got a niche somewhere. There's hiding something that's causing pain. And I guess the big thing there may be emotional or physical abuse, which is not easy to talk about. And some people don't even realize it, but it can certainly cause a multitude of pain generators or causes of pain in the pelvic area. How is your sexual function? Are you able to complete the activity? We're going to touch on that a little bit. And what comorbidities do you have? What other autoimmune diseases do you have? Because there are several associated with bladder pain syndrome and interstitial cystitis. Questionnaires. Here's just a few. We tend to choose ones that have been validated, meaning that they've been scientifically proven to have good evidence. The Urogenital Distress Inventory, that's a bother index. International Incontinence Questionnaire, Symptom Severity Index, because a lot of people do have incontinence and pain. Bladder Floor Impact Questionnaire, another bother. How much does it bother you? The O'Leary Symptom and Problem Indices. The symptom is symptom severity, and the problem is how much does it bother you? Pelvic floor distress inventory. How much do the pelvic floor disorders, prolapse, for example, defecatory problems bother you? Visual analog scale for pain and sex, a scale of 0 to 10. We kind of see where you gauge yourself. And the female sexual function index, of course, for women, symptom severity, satisfaction. And a mirror in men is the International Index of Erectile Function, symptoms, bother, and satisfaction. Okay, symptoms. So this in bladder pain is pain or pressure or discomfort associated with the bladder, or it could be referred to the lower back, inner thigh, frequent urination, the urge to go, delayed or decreased emptying, and it may feel like your bladder is on fire. Urethral pain, and sometimes bladder pain gets referred to the urethra. You have intermittent or persistent symptoms they feel in the urethra, and it's usually felt during urination or is associated with urination, voiding, and or intercourse. For male genital pain, there's penile, testicular, scrotal pain, and it can be pain, pressure, or discomfort. Enough bothersome that you want to just grab and hide away. Female genital, the skin, the vulva, vulvar, vestibular, or clitoral pain. Uterine or tubal pain, dysmenorrhea, painful menses, infection, endometriosis, and growth in the uterus called adenomyosis. The vaginal dyspareunia can be superficial or deep pain with intercourse. Pelvic floor pain is musculoskeletal. It may be prolapse with bulging. It may be evacuation dysfunction with high tone muscles, and again, painful sex. Pelvic organ malignancy can cause urinary or bowel dysfunction, pain following pelvic surgery, can be secondary to organ or nerve injuries and can have a discharge from the vagina or exposure of mesh. The GI tract we can't forget about, and we usually send them to the GI people because they have a lot of things to look after, as you'll see. It's basically anal rectal or colorectal. Anus and colon, anus being at the opening of the skin. Chronic proctalgia, rectal pain for more than 3 months, and it's episodic, meaning it doesn't last long. Levator ani syndrome, not unlike high tone pelvic floor dysfunction that we see with the bladder and the skin. Proctalgia fugax, recurrent episodic, and these last seconds to minutes, pain in the anal rectal area. Pain specified with sitting and defecation, usually due to high tone muscles. Anal fissure, bright red bleeding with the bowel movement. Anal pain and spasm is the result. An abscess, you get pelvic rectal pain and straining, tenesmus. Hemorrhoids, you have anal discomfort, engorgement, pain, and itching. A lump in the perineal area, internal hemorrhoids, painless bleeding, mucus discharge, incomplete evacuation. Not so unlike the bladder, but a little more places to go wrong because the colon's a long tube. Crohn's disease can cause an anal pain during a flare. And others, colorectal, irritable bowel syndrome, which is recurrent abdominal pain more than 3 days a week for more than 3 months. And 2 or more of the following. There's improvement with defecation, change in the bowel movement, frequency or formation. Doesn't that sound familiar? Like when we have painful bladder pain syndrome, I see. There's a huge crossover between irritable bowel syndrome and bladder pain syndrome. Colitis, abdominal anal pain. Crohn's disease, again, can be of the colon, even of the small bowel, and it's abdominal pain. Okay, musculoskeletal, we get pelvic floor muscle pain, pain with sitting, possible bladder and bowel evacuation dysfunction, vulvodynia, dyspareunia, painful sex, and myalgia, pain in the muscles. Coccyx pain syndrome, pain in the coccyx, unresolved after 2 months. It's provoked by sitting, bicycling, bending over, standing. It may also include introital dyspareunia and bowel evacuation dysfunction. So now that's going to cause dysfunction again in the bowel and or bladder. Sacroiliac joint pain, you have pain with bulking or bending. And then there's something called the sacrospinous ligament, which is a big ligament. And that can cause pain with sitting. Also because when the muscles get tight, they push on the pudendal nerve and certainly can cause pain. And then the levator ani syndrome, pain with sitting and bending. So everything's connected, whether you have the inner pelvic floor muscles or the outer pelvic floor muscles. It even goes into the back and the neck. So nerve pain, pulling and throbbing that limits physical activity. As you can see, there's a lot of nerves in the area of the low back and pelvis, those things in yellow. And you can have infiltration of the sacral nerves, which causes perimenstrual bowel bladder evacuation problems, and it causes dysfunction during sexual activity. Body neuropathic pain. This is a nerve injury, often associated with surgery, car accidents, and it causes entrapment. Sometimes during surgery, the nerves also get accidentally sutured, and the suture goes around the nerve, which would be an injury. Okay, what have we heard a lot of lately? We've heard a lot of pudendal neuropathy, which is a constant burning, intense, lancinating pain. However, diagnostically, there is no pain when you're lying down. Again, one of the common things that we see is not a direct injury to the nerve so much as having the muscles get really tight. And what happens is they push the nerve against the bone. So the nerve is in between the bone and the sacrospinous ligament. And when that happens, it can cause compression of the nerve. So we always recommend treating the muscles, such as pelvic floor physical therapy, trigger point injections, and even Botox injections to make and Valium suppositories to make the muscles relax. And that tends to get rid of the pudendal neuralgia. Neuroma formation. It's continuous neuropathic pain in the nerve distribution office. This is found after surgery, and it's because of scar tissue. Okay, NEUI, pain following mesh surgery. It's pain or bleeding during sexual intercourse, and the partner sometimes has his periunia or pain because of the penis touching the mesh, and it's pain during physical activity, spontaneous pain, or even feeling the mesh yourself and often having a vaginal discharge. And here you can see the mesh exposure. Now, let's not forget about the psychological overlay, which occurs in up to 80% of patients. And that includes fear, with agitation and dread, the imminence of danger, mood changes. You don't know what's going to happen. You have fear of sex. You avoid sex. Anxiety, again associated with fear and a panic attack. Depression with an altered mood, sadness, despair, sexual dysfunction, thoughts of death, suicide, sleep disorder. Catastrophizing, which is an exaggerated orientation. It's kind of a maladaptive coping mechanism with a lot of worry, and you feel very helpless, hopeless. And this is not in your control, and it doesn't mean you're crazy. It just means that when your brain, the pain in the pelvic area or other areas of the body always goes to the brain somehow. It's called nerves, and there are different areas in the brain that are affected, and a lot of our neuroscientists now are actually studying that. So one of the coping mechanisms or adaptive mechanism is catastrophizing. Anger. More than 70% of people are angry because they're just enraged because of the dysplasia, and they even may become hostile, which is why it's important sometimes for us to consider psychotherapy to help with stress management, and also things like yoga to get all of the steam out, so to speak. Okay, let's talk about sex just a little. And this is for men or women. Is the sexual concern present in all situations or just a few? How long has this been going on? And how bad is it? Your concern or bother, that is. What are the personal distress and interpersonal difficulties? How does this affect your relationship? Is the concern culturally sensitive? We certainly know that different cultures have different beliefs on sexual behaviors. Is there a history of abuse, emotional, physical? Is there more than one sexual concern? Desire to have sex, arousal, getting excited, orgasm, sexual pain? And which is most troubling, which is why it's helpful to fill out those questionnaires. Are there problems with the blood vessels? We call this vasculogenic. We should probably, in both men and women, check the hormones and check for metabolic syndrome, which is associated with abnormal blood work, heart disease, high blood pressure, high lipids, diabetes. What medications are you on? Have you had chemotherapy or radiation? Are you taking drugs that affect the brain or central nervous system? Are you using hormonal agents? What is your self-perceived body image? Again, the degree of bother. And regarding surgery, your partner's, his periunia, which is a new term, by the way. Okay, we know that other autoimmune diseases are associated with bladder pain syndrome, IC. Autoimmune disorders, chronic fatigue syndrome, things like Sjogren's syndrome, temporomandibular joint disease or tightened jaw, fibromyalgia, generalized hypersensitivity, even asthma, sleep disorders, and you can see there are quite a few. The best studied in association with interstitial cystitis are chronic fatigue syndrome, fibromyalgia, endometriosis, irritable bowel syndrome. And as we can see, there's a huge overlap that causes prolonged fatigue, which results in pain. It feeds the cycle. Then you get poor concentration and you get an irritable mood. All right, let's go on to the next phase. My examination equal the physical examination. And these are called signs. And I'm going to try to help figure out, based on your history, which is now very thorough, what's going on. And I may make a couple recommendations for further testing at this time. I'm going to look at the vital signs because I can see what your weight and body mass index is, which is important to certain pelvic floor disorders. Do you have high blood pressure? Your mood, I can observe you. Do you look anxious? Are you depressed? Do you have no eye contact? Are you looking down? Then I also observe your posture and your gait. As we can see here, there should be a straight line. It's not unusual for a chronic pelvic pain patient to have the head tilted forward 5 degrees or more. When they sit, they're sitting in a slouched position with an exaggerated curvature of the thoracic spine. And when they walk, they tend to put their pelvis forward and kind of waddle more than walk because of the pain. Okay, now with signs, lower urinary tract, bladder pain. It's in the suprapubic area, and also in women, it's in vaginal. You examine anterior or in the front, and you feel a tender bladder. In the urethra, you can feel a tender urethra, and men and women. And especially in patients who complain of a feeling of decreased bladder emptying, we want to get a bladder scan. What this will do is measure how much urine is in your bladder after you've urinated. And we tend to do that at the first visit. We may give you, by the way, you fill out your questionnaires before you come in. We mail them to you or email them to you. And then we usually give you a voiding diary. And this will give us some information about what time it is, how much you urinated, what you were doing. And if there's any leakage, was there an urge present? I mean, if it was yes, and it was severe, you can say severe. And of course, how much fluid are you taking in? And once we look at that, we may then want to go on to something called urodynamics, during which most people contract their muscles as they're trying to pee. And we can see if there's any incontinence and if we can reproduce the pain. We can also go to cystoscopy. I think the recommendations are changing right now. If you have blood in your urine or you have chronic pain, we're tending to look in the bladder in the office with a little anesthesia in your bladder to see if you have a Hunter lesion, which is maybe in the future treated differently than without a Hunter lesion. Okay, male genital pain. We look for penile, epididymal, that lays on top of the testicle, testicular, and prostate tenderness. Oftentimes, the penile pain, scrotal pain can be reproduced when you push on the prostate. And that is located right here, as most men may know. And we always have to consider erectile dysfunction because, again, it goes along with sexual pain. So we want to check the blood vessels. So this is a Doppler study, and we want to see nice brisk peaks. Then we also want to see how well the penis can maintain an erection. So you can put tape around the penis and do what's called nighttime or nocturnal tumescence. And basically, we want to see how many times there's an erection during the night. Female genital pain. In the vulvar area, we look for tenderness. We look for fissures, ulcers, inflammation. We can look in the uterine tubal area, where we usually look at a cervical discharge. You might feel a mass that's tender next to the uterus. You may have an enlarged uterus. You may have motion in the cervix. When you move the cervix, you may get tenderness there. Dyspareunia. Again, we always want to identify all the pain generators in pelvis. So in the pelvic floor muscles, we look for trigger points in the muscles. It's tone and tender points. The trigger point is a tender point. If they have prolapse as well, we get a POP-Q score. Don't forget, you can have pelvic organ or have had pelvic organ cancer or malignancy. So you look for a mass, you look for radiation changes and scarring, and pain following pelvic surgery, tenderness, a vaginal discharge, extrusion of mesh. And again, this is a new category. And it's become more prevalent, as you may know. Okay, now we're kind of looking at the vulvar area. Okay, so this is the labia majora, labia minora, and here is the vagina, and here is the urethra. Anterior fourchette, posterior fourchette. These tend to get scarred and may have cracks or fissures with things like lichen sclerosis, which is an inflammatory disorder, but we also check the Skene's gland ostia and the vestibular ostia, because they are tender and oftentimes red in vulvar vestibulitis. We used a Q-tip, and you can see there's a little redness here, and that will obviously be very tender in someone who has inflammation of the glands. So if we want to get a little fancier, we can always use what's called an algesiometer. Normally, with the cotton Q-tip touch test is what we showed you. This is just putting that Q-tip on a standardized pressure gauge. Now, we can also, especially in younger people, we may want to do colonoscope, or excuse me, colposcope, so that we can check the cervix, do a biopsy, etc., if needed. And again, we do questionnaire-based, we do cultures, we do X-ray studies, and in the muscles, we can do trigger point injections. We can use the ultrasound, the MRI to identify problems with the muscles. Pelvic organ malignancy, obviously you must know, involves a tissue or pathology and some sort of imaging. And then what do we do in the patients who have had mesh? You can get an MRI to find the mesh, but now I think they're showing it's more sensitive to get, because we have we have now 3-dimensional ultrasounds, and they can actually see the mesh. I just saw a very interesting video on that. Okay, we mentioned before pain maps, because here you have the severity of the pain and you write down what region it's in, anywhere in the body. So if you have skin pain, vulvar pain, penile pain, scrotal pain, which we always also want to check if there's pain somewhere else, because there is a group of patients or a phenotype that definitely has other pain in other areas of the body. And this group of patients is upregulated, have central sensitization, just meaning that they're more sensitive to things. If I hit myself, it doesn't really hurt too much. But if I hit like you like this, it might hurt like you know what. And that just means that you're upregulated, and it's more than in the pelvis and bladder. And sometimes I think going forward for phenotyping or classifying groups of IC bladder pain syndrome, it's becoming more important to do scales like this. And the GI, again, identify the pain generators, because there's a lot of them. Okay, the signs of the muscle pain. Again, we have pelvic floor muscle pain, tenderness in the tone over the pelvic floor muscle. So you look for trigger points. You look for trigger points abdominally and vaginally, with increased tension or tone on examination. And here you can see that we do the back muscles, we do the high pelvic floor muscles, we look at the levator ani muscles, which are like a bowl. And when you think about examining someone or examining yourself, our physical therapists will oftentimes have you dilate yourself. When you think about that, it's much easier to visualize if you think of the bowl. Coccyx, usually there's pain in the sacroiliac joint, which is up here from the back, and it hurts when you bend over, and it tends to be on one side. You may even have sciatica or pain going down the back of your leg. And you can have tenderness over the sacrospinous ligament. And the levator ani syndrome will show you a better picture. Again, you actually go transrectally or transvaginally, and you find tone and then tenderness, and then you try to find really areas that are really tender, that reproduce the pain, which is called the pain generator, or reduce the pain or reproduce the pain by referring it to where the patient feels it. The bottom line on this physical exam is you want to reproduce the symptoms. Okay, so standard evaluation of pelvic floor muscles is for strength. 0, they can't. 5, it's like Olympic bladder training or Olympic muscle training. They can hold the muscle tightly and sustain it. Basically, most commonly, we go into the vagina and we go over on the right and the left-hand side and we examine each of the muscles. So we basically use the clock. 6, 9, 12. But we can also measure these trigger points and the tone, because most of these patients, the muscles are hypertonous. They have high tone and they cannot relax. So 0 means you're pretty normal. 4 means there's severe pain with the examination and you're unable to contract the muscle and you can't relax the muscle. And we usually do this with our finger examination. If you want to get real fancy, they've got something now called a dynamometer, which is not quite available yet, but probably will best be the best tool. But for the meantime, we do our finger or digital exam and something called a perineometry. You have an anal probe, or this is a vaginal probe with a condom over it. And it's a very simple thing. You're asked to relax, contract, relax. When the machine is zeroed outside the body, and then we put the machine inside the vagina or rectum, and you're told to contract, relax, contract, relax. And when they compared that with a good set of hands, they were probably pretty much even. But it's a nice extra little tool because you can actually show the patient the numbers and show them that with high tone, they can't relax. But this would be their baseline at 33 or more, and they can't contract up to 90 to 100. They can only contract to 40 or 60. Can't contract, can't relax. Okay, so it's a little hard to understand the pelvic floor anatomy because it is in 3 dimensions. So the first layer, bulbocavernosus, ischiocavernosus, and transverse perineoids, these shallow muscles here. And they control the vaginal sphincter. They impede drainage from deep dorsal veins from the clitoris, which makes it responsible for clitoral penile erection. This comes from the pudendal nerve, which is located in the sacral spinal area at S2 to S4 out of 5, S1 to S5, S2 to 4. This is deeper layer. Here's this bowl thing. Now, this is looking from the top down, and you basically can see the pubococcygeus muscle, which goes around from the sacrum to the pubic area, goes around everything. Puborectalis is responsible for anal continence. So in the back, at the rectum, under this, you can't quite see it. It kind of goes in this kind of direction, and it puts resistance for fecal continence. And then we have the iliococcygeus, which goes outside. And then we have the coccygeus, which goes to the back and down. No, but what it is, it's a bowl or a wine glass, if you so prefer. All right, so sometimes even during the first examination, we want to show the patient that their muscles are not going down all the way to baseline, contracting. Sorry. So what you want to see is all the way to baseline, and then a contraction, the sustain, and go all the way down. So when we send our patients to physical therapy, which we do, and probably almost 100%, this is what it looks like. They can't contract and sustain it, and they can't relax. So rather than teach them just to do Kegel exercises, we actually teach them how to relax by deep breathing, by stretching, by strengthening the opposing muscles. And if nothing else, we can't figure it out, an MRI of the pelvic floor can be useful because it can tell us what the muscles are doing, make sure there were no birth injuries with the muscles here. They're pretty intact. Size of the bladder. If we look from a sideway view, we can see if there's any droppage or prolapse of the organs. Nerve, physical exam. And there's local tenderness with a combination of redness and purulent discharge. And again, the mesh extrusion, which we showed you. And oftentimes the muscles around the mesh arms will also get tight. So we always try to do a nerve block if they've got evidence of pudendal neuralgia, and we always do trigger point injections to see if we can feel where the mesh is and if the mesh is tender or if it's the muscle that's causing the problem. And then we decide if it's the mesh, we can cut the mesh arm. You can never get all the mesh out, but people can do well with limited surgeries. And we then may decide, we can do this in the office. I did one today. This is biophysiometry. It tests with vibration. You can test the distribution of the pudendal nerve. Not a wonderful test, but sure as heck is easy and gives the patient and you an idea of what their sensation in the distribution of the pudendal nerve, which can be the clitoris are the clitoris, the labia, and the perianal area. Okay, so the workup of BPSIC, a comprehensive history and physical examination with a referred out appropriate evaluation, allows identification of all of the pain generators that need to be treated, all that need to be treated in addition to bladder pain. The pain generators may be localized to the bladder, pelvis, or they can be systemic and located elsewhere in the body. And I want to thank you for your attention. And now I know you're going to understand everything there is to know about the workup of BPSIC. Thank you.